Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCrae.
Uterine fibroids, or fibrous tumors of the uterus, they're more common than you might think. In fact, doctors perform more than 200,000 hysterectomies, that's removal of the uterus, every year to get rid of uterine fibroids. Not for cancer or anything else, but for uterine fibroids.
But there are now other options. Here to talk with us about uterine fibroids and the newer alternatives available for treatment is vascular and interventional radiologist Dr. Knavel Koepsel. Very nice to meet you.
Very nice to meet you as well. Thanks for having me on the show.
Thanks. You know, we don't have radiologists very often, but we particularly don't have interventional radiologists. What's the difference between an interventional radiologist and a regular radiologist?
Right. So a diagnostic radiologist will specialize mostly in interpretation of different imaging modalities, such as CT scans, MRIs, ultrasound, and other various modalities. Some diagnostic radiologists also do procedures. The difference is in vascular and interventional radiology, we primarily only do procedures. So we actually do procedures inside the blood vessels, inside the arteries and the veins. We do interventions into the chest and organs in the abdomen. So we treat a whole variety of diseases.
What's the most common thing you do as an interventional radiologist? I guess it would vary, but what do you do?
What do I do? So it can vary from day to day, and that's some of the enjoyment of the practice. One of the things that we do quite often is central venous access, so putting in lines for chemotherapy and nutrition and durable venous access. Some of the things that I specialize in personally are venous disease. So if there are veins that are narrowed, I help go in, open those veins back up, and place stents in order to restore flow. I also specialize in complex IVC filter removal, so filters that have been in for many years, even decades. We can go in and take those out. And the other thing that I specialize in is uterine artery embolization. So that's what we're going to talk about today.
Yeah. So first of all, it seems like everyone I know at some point has to have a conversation of they either have a fibroid or they might have a fibroid. Mm-hmm. So it must be pretty common.
They are definitely very common. And a lot of times many women have them and don't even know because they can be completely asymptomatic or without symptoms. When they start to cause issues is when women present to their gynecologist usually for further workup.
And when they are symptomatic, what does a woman feel? What does she notice?
So there are a variety of symptoms. Some are related to heavy menstrual bleeding because of where the fibroid is located within the uterus. There are also symptoms related to kind of bulk of the fibroid. If you get really large fibroids, they can cause some pelvic pain, pelvic pressure. It can also cause you to have frequent urination, and also many women can even suffer from constipation. So kind of a wide variety of symptoms.
So tricky because it's one of those things, you know, you're like middle-aged and then it's the beginning of menopause, or, oh no, I've gained too much weight, mm-hmm. or there's so many, again, things that can play into that. It takes
Right.
a long time to figure out.
Right, and that's true. The women who most commonly have fibroids and are symptomatic from fibroids are usually in the childbearing years. Mm-hmm. The fibroids are stimulated by estrogen and progesterone hormones that are in abundance when you're in your childbearing years, and actually after menopause, the fibroids can decrease in size and become less symptomatic as that estrogen and progesterone levels decrease.
Yeah, pretty interesting. So heavy menstrual periods is probably the key symptom. Yeah. And then you mentioned constipation and some of these other symptoms, which suggest to me that these things must get pretty big sometimes.
They can be up to, we've seen them 14, 15 centimeters in size, even larger.
So that's like 5 or 7 inches or so.
Right. So
really?
So they can be quite big. And when they're that big, you think of how much space is in the pelvis, they tend to put pressure on either the bladder, which causes you to have frequent urination, or they can put pressure on the bowel and the rectum, which makes it more difficult to go to the bathroom.
So previously, that would be removed, the fibroid would be removed, maybe also the uterus removed at the same time. And how can you help? Because having your uterus removed is kind of a big deal.
It definitely is a big deal, and I'm glad we have a variety of treatment options available to us today. The one that I specialize, uterine artery embolization. This is a procedure that we have been doing for many years and have had some really excellent results with. What we do is we enter through the enter into the arterial system or into one of the arteries, either through a small artery in the wrist or the artery in the groin. Then we feed our catheters and wires into the 2 arteries that are feeding the uterus.
All right, now you're watching this on a fluoroscope, right? So
Exactly.
you can see where this catheter is going,
Right.
so it doesn't wander someplace you don't want. And
Exactly.
you can guide it.
Yes.
All right.
So we use real-time x-rays to help guide our wires and catheters into place. Once we are in the uterine artery, we inject contrast to make sure that we're where we think we are. And we usually see filling of the fibroid with the contrast material that we inject.
So you're finding the artery that actually feeds the fibroid.
It feeds the fibroid and the uterus.
Okay, but aren't you worried about cutting off the blood supply to more than just the fibroid?
That's a reasonable
the tricky
concern.
part?
Yeah, that's
Yeah.
a tricky part. You have to kind of know when to back off on your embolization or when you should proceed. But preferentially, a lot of the blood flow goes to the fibroids. So as a result of that, a lot of the embolic material or the little particles that we
All right,
inject.
now we got to stop embolic. So tell us what you're doing, what you mean by that.
So when we say embolization, it basically means to shut off or occlude or block an artery.
You're plugging the artery.
Plugging the artery,
Okay.
exactly. So a lot of the blood flow preferentially will go to the fibroids. So when you're injecting your material that you're going to use for the embolization, it will preferentially go to the fibroids first.
And what material do you use to plug it?
So we inject small permanent spheres. They're very tiny, on the micron level of size, and they go into the arteries feeding the fibroid and just plug up those arteries feeding the fibroid. And then we keep the main uterine artery patent or open so the rest of the uterus can get blood supply.
And I should say, I said it's a big deal to remove the uterus. Why is it important to keep that uterus if possible?
There can be some structural changes that happen after a uterus is removed. It is tethered to the pelvic wall by certain ligaments and helps to keep the structure of the pelvis. Sometimes when the uterus is removed, you can have difficulty with some laxity within the pelvis. We're noticing that there may be some other kind of metabolic changes that happen as well.
So trying to keep it is important.
Yeah, and I think a lot of women, even though they may not be wanting to have more children or anything like that, that's an important part of them and they want to keep it.
How long does it take after you've injected this material for I assume that the fibroid will then shrink. How long does that take?
It can take up to a couple of months for it to shrink. So it's a slower process, but women usually can have some initial relief about 3 months after the procedure.
Do you sometimes have to do this more than once?
Occasionally we do. Sometimes the fibroids are supplied by accessory arteries or additional arteries besides the uterine artery. So if that happens, we can go back in and make sure we embolize those arteries as well. It's a little bit less common. And then sometimes if the fibroid's so big, sometimes we can get some initial shrinkage. But
is it a pretty successful procedure?
It is a successful procedure. Rates in the literature for shrinkage of fibroids are between 40 and 75%. So there's a little bit of variation, but I think sometimes women just need a little bit of the shrinkage to get the symptoms under control.
Are there any other modalities short of a hysterectomy that might be as good or that women should consider?
In addition, as an alternative to hysterectomy,
embolization, yeah.
to embolization, alternatives to embolization, there are many. We usually start with more conservative measures first, so that would be like medications to help regulate some of the hormones. The only unfortunate part about that is once you stop taking the medications, then the fibroids can regrow again, become more symptomatic. Women can have IUDs to help control their heavy menstrual bleeding, which is important. We also have some other techniques, surgical and non-surgical, that we can perform. So one of them is MR-guided focus ultrasound. In this procedure, we use the MR scanner to locate the fibroids. Once the fibroids are located, we can focus a beam of sonic wave or ultrasound energy into the fibroid, which basically heats it and destroys the fibroid that way. So that's an excellent procedure as well. And then there's some of the other surgical procedures, going through the abdomen to remove the fibroids, going through the vagina into the uterus to remove fibroids. So there are a lot of different options. And it's best to have a well-rounded discussion with your gynecologist and interventional radiologist to discuss.
Well, uterine
these
fibroids,
procedures.
they're certainly common, and it's good to know that there are a lot of different options for treatment. Traditionally, it's been hysterectomy, but now a lot of other options for women who have this problem. Interventional radiologist Dr. Knavel Koepsel, thanks so much for being with us.
No problem. Thanks for having me.